Good evening, everybody, and welcome to our Sports Surgery Clinic webinar and evening for tennis players. I know that everybody has been off court for a long time with the lockdown and restrictions, and this week everybody's getting excited to get back on court. So it's probably a good time to talk about some tennis-related things. My name's Ruth Delaney. I'm a shoulder surgeon here at Sports Surgery Clinic. And we're going to talk a bit about some things that pertain to tennis and shoulder injuries, and my colleague Neil Welch, who's a strength and conditioning coach, is going to speak to you about also some low back issues. Everybody's been off court for quite a long time with lockdown and restrictions, and only this week getting excited to get back on court. And one of the most important things is going to be warming up and stretching properly, and Neil is going to take you through some exercises that are going to help with all of that. I'm going to talk about a few other things to do with tennis, and then we'll get into some shoulder things. So let's talk about tennis, and where better to talk about tennis than from Wimbledon, although I wish I was actually there. Who knows if anybody will get to be there this year. Tennis has been part of my life for a long time, and my parents took us to Gary Duff, which was up the road from where we grew up, and put us on the tennis courts there. We were really lucky to get this background in tennis. Lucky that there was a young coach there named Declan Bray who was willing to teach some kids how to play tennis, and it was for quite a number of years a big part of life, and it's really a great sport. So I'm glad that we can do this evening and talk about tennis and the shoulder. I did most of my shoulder training in Boston, having graduated from UCC, and got to train at Mass General on the Harvard Orthopaedic training program. And then as a shoulder fellow in my last year of training doing just shoulder surgery, spent time in France, in Annecy and in Lyon, before coming back to Dublin in 2014. Shoulder pain is really common. Up to 70% of us are going to experience shoulder pain at some point in our lives. And about a quarter of people who have shoulder pain, it's not their first time having it. It can have a significant effect on people's lives in terms of sleep disturbance and work absences. And so it's something that is a really important part of musculoskeletal medicine. So one of the things, if you're dealing with a shoulder or arm injury and playing tennis, or if you're trying to prevent running into trouble with your shoulder, is to have your equipment optimized as best as you can. And so talking to your tennis coach or your club pro about that is really helpful as well. So with tennis rackets, everybody has their own preferences. I've had these tennis rackets for a long time and they suit me really well. The grip size, though, is really important, and that's something that it's worth taking a bit of time to talk to whoever you're buying your tennis rackets from, talk to your coach and have a look. Because if you have a grip size that's too small, then you're going to be gripping the racket really tightly because you have to hold on to it. That's going to lead to strain coming up here, which is where we get problems with tennis elbow, and can lead to problems with your shoulder. If you have a grip that's too big, you're not going to be able to get your hand all the way around it, and you may run into trouble with your wrist. So having the right grip size is a really important place to start to prevent injuries and not to aggravate any underlying issues that you might have. One of the simplest ways that I was taught when I was growing up playing tennis to figure out what grip size I should have was just to have my hand on the racket in my regular forehand grip or semi-western grip or whatever you like, and then see when I fit my thumb in between my fingers and sort of the heel of my hand here, or what we call the thenar eminence. So put my thumb right here. If that fits nicely there and there isn't a huge overlap or there isn't a big gap, then I've got about the right size grip for me. And because all of us obviously have slightly different sized hands, so finding the right grip size for your tennis racket is going to make your arm, your elbow, your shoulder much more comfortable when you're playing. The other thing with your racket is obviously your strings. I'm guilty of this. I haven't restrung this racket in ages, and that's because we haven't been playing in a long time, and I think most of you out there are probably the same. So before getting back on court, it's good to check in and get your rackets restrung. Your club coach will be able to advise you on whether there's someone in your club who can restring your rackets for you, and get advice about the type of string and the tension that you want to put in it, depending on whether you're somebody who needs help generating more power. So you might want to go down on the tension a little bit so that you're not trying to use your shoulder and your elbow to generate all of the power. Or if you're going to go higher on your tension, that's going to give you a bit more control. And there are lots of other things about the type of string and and all sorts of variations. So again, get advice from the professionals who can help you with that, and that will not only help your tennis, but help keep you out of trouble with injury as well. Some players used to like shock absorbers on their strings. That's a personal preference. A lot of us find that they just damp the feeling, and it's sort of a different sensation when you're playing. And they've kind of gone out of vogue a little bit, but some people still like them if they have trouble with tendonitis issues in wrist and elbow and the vibrations coming through the racket. So your strings are important as well, and your grip size, and getting good advice on all of that before you get back out on court can really help. So this week, everybody is looking forward to getting back on court. Some people have maybe already gotten back on court since Monday. And I think there are lots of different aspects to that. Adult players and seniors who like to play doubles all the time are maybe feeling a bit upset that doubles is only possible with people in your own household and maybe not so comfortable playing singles. But if you're smart about it, everybody can play singles. Maybe you just play in half the court and use the tram lines. Maybe you realize that for the sake of your shoulder or the rest of your body that you're not going to serve overarm all the time, because remember, when you're playing singles, you're going to hit double the number of serves. But everybody can get back out and play singles in a way that works for them. I think a lot of the juniors have been very frustrated with all the time away from courts, or maybe trying to find some ways to hit on court somewhere. But it's okay if you went a few months without hitting. It'll all come back, it'll all catch up. And for the juniors too, being smart in terms of warming up properly and being patient to get back into your rhythm, and everything will start to happen again. One of the other things about gear that we sometimes forget about is the tennis balls that we're using, and especially in our Irish weather. It doesn't take long for the tennis balls to get damp and wet, particularly if there's a bit of rain out there. And so depending on your tennis balls, this one's been used a bit, it's kind of starting to fade, it's still perfectly fine to play with, but after a while, tennis balls may start to get wet, and there's absolutely nothing wrong with opening new tennis balls halfway through your session. It's not just the pros who get to say new balls please every 7 games, and okay, it adds expense, but if you're somebody who has trouble with your shoulder or your elbow playing tennis, then it's something to be conscious of. If it's a wet evening and you're playing tennis, it might be an idea to bring an extra set of balls and halfway through just open a new set of balls, so you have a nice, light, dry set of tennis balls, particularly to be serving with, so you're not putting extra stress down through your shoulder when you're hitting. The serve is probably the best example of the complex biomechanics involved in tennis, and how when they don't happen the way they should, the shoulder can get in trouble. This is from a recent article published by Alan Curtis and his team from the New England Baptist Hospital in Boston. And this diagram shows us the phases of the serve and starts to get us thinking about what we call the kinetic chain. There are a couple of things about your technique when you play tennis that can help save your shoulder as well. I'm no tennis coach. When I did my level 1 coaching qualification, as it was called back then, it was quite a while ago, so I'm pretty sure it's out of date. So your tennis coach in your club and your own tennis coach can work a lot with you on things that can help if you have an injury or if you're trying to prevent an injury. But there are a few basic things that we'll mention tonight just to have you think about as you get back on court. One of them is footwork, and it's easy to get lazy about footwork and not get your feet in the right position, so that if the ball is out there, we're doing something like this instead of actually getting our feet there, and that's going to help you in terms of saving your shoulder and your arm. So getting yourself in the right position early, whether it's singles or doubles that you're playing, that's going to be important. The other things that can help in terms of shoulder is that we need to remember not to let the shoulder always be taking the brunt of what we're doing on the tennis court, because the shoulder is part of what we call the kinetic chain, which includes your legs, your hips, your trunk, and then your shoulder, your elbow, your wrist, and your hand. And that goes for every shot that we play. So if you're hitting a forehand, that'll often start from the ground up, whether it's an open stance or a more closed stance. You're still going to get yourself ready and have that body rotation and lead with your hip rotation, so that it's not all coming from the shoulder. And so that if you do have any issues in your shoulder, you're protecting your shoulder by actually using the rest of your body. And the same applies to your backhand, whether it's a 1- or 2-handed backhand, or whether you're hitting a serve. It's going to come from the ground up, legs, hip rotation, trunk, and only then your shoulder and arm. And so that's something to work on with your tennis coach at your club. So thinking about all of that, then it's legs from the ground up, the trunk, the shoulder girdle, and then the upper extremity or the arm. And so we run into trouble if it's all coming from the shoulder. The legs and the core should provide a stable base. The shoulder blade is key. It's a stable platform for the shoulder to function in general, not just in tennis. It protects the rotator cuff if the shoulder blade is working properly. And something that we call scapular dyskinesis, or basically the shoulder blade not moving the way that it's supposed to, gives a really highly increased risk of shoulder pain in overhead athletes, including tennis players. There are these key points during a serve action, for example, that are referred to as nodes when we're talking about biomechanics. And if any one of those isn't happening correctly, then it can lead to another downstream effect that can result in injury and overuse. And again, this is from Curtis's paper. And I think it's interesting to just think about this, that your foot position can affect what's happening with your hip and your trunk. Same with your knee motion as you go into a knee bend and then extension through contact with the ball and all the way up. And the scapula and the shoulder are almost like a funnel directing all that force from the ground up towards the arm and then finally into the racket and into your serve. So all of these things are important in protecting the shoulder when you play tennis, and that's why the tennis coaches spend so much time getting all of these things right for their tennis players. In terms of shoulder symptoms that we see, a lot of times it's shoulder pain as the main reason why people come to see us. It can also be stiffness or weakness, or sometimes it can be an issue with shoulder instability. It's also possible that some symptoms that you feel around your shoulder can be coming from a problem with the neck, and there can be overlap between a shoulder problem causing neck pain or a neck problem causing shoulder pain. So sometimes we end up looking at both. And when we assess shoulder problems, we take a history, try to figure out the pattern of what's happening, and then examining the shoulder gives us a lot of really useful information. Usually we'll want some imaging. Sometimes x-rays are more useful. Sometimes an MRI is helpful. It depends what's going on with the shoulder. And sometimes we use other things like CT scans. 4 of the main things that we see with shoulder problems are the rotator cuff, which you've probably heard of, frozen shoulder, which is quite common, arthritis of the shoulder. And often in younger overhead athletes, there can be issues with instability or tears of the labrum, which is the cartilage bumper around the socket of the shoulder. And in tennis players, there can be very particular patterns of those labral issues in younger tennis players. Often those are things that we do not treat with surgery. When there are problems that we consider shoulder surgery for, I think it's important to get advice from a shoulder specialist. There are a lot of things on the internet out there, and you have to be careful where you get your information. And a shoulder specialist will walk you through the risk-benefit balance of considering surgery or non-operative management for a problem. What's really important for active people like tennis players is, of course, the recovery time, the rehabilitation involved, how long you're going to be out of action. And preparation for the surgery is important as well. And knowing some of the background of what's involved in your surgery is the job of the shoulder specialist to show you and teach you. At our practice, we like to be really meticulous about following up the outcomes of our shoulder surgeries as well, based on the principles of Ernest Amory Codman, who was a shoulder surgeon from over 100 years ago at Mass General, who actually got thrown out of Mass General for having the cheek to suggest that surgeons should be held accountable for their outcomes. And now, over 100 years later, that's something that I think the whole world of surgery embraces. So if we do a shoulder surgery, the patient fills out surveys at various points after surgery, and that shows us if that patient is on track compared to our averages and the averages of a whole load of other practices all over the world. And so that keeps our standards on a par with everywhere else. To go back to these specific problems that we see in the shoulder, if we talk about the rotator cuff, a lot of people hear about the rotator cuff, and a lot of times any kind of shoulder pain is called a rotator cuff problem, which may or may not be the case. But the rotator cuff are these 4 muscles that are deep inside the shoulder. So this shows a front and a back view of those 4 muscles. And their job is to help compress the shoulder in its socket and to help raise the arm, as well as obviously perform rotation. So the rotator cuff does a lot of work when we're playing tennis. These tendons haven't got a great blood supply, and they do tend to wear over time. There's a certain element of normal wear in the rotator cuff. So if you get an MRI scan of any shoulder over the age of about 40, you'll see some normal wear and maybe even partial tears. Those are often not things that we have to fix surgically, but they may cause pain or inflammation. Full thickness tearing, where the tendon tears away from the bone, is something that we sometimes consider surgery for. Things that cause inflammation and pain will often be treated with physiotherapy. An injection may have a role in it. Things like steroid injection or cortisone, or sometimes some other types of injections. And those may help settle things down so that you can then work on your physiotherapy, retrain the muscles around the shoulder blade to get back to that shoulder blade control, and again, enable you to get back on the tennis court without necessarily having surgery. If there's a full thickness tear, it might be something that we recommend repair for, depending on the size of it. And that's usually a keyhole surgery to reattach the tendon, but the recovery takes time afterwards. You're probably looking at about 5 or 6 months before you get back on the tennis court after a rotator cuff repair. And that's something that we try to take time to explain beforehand, so that we set everybody's expectations appropriately for afterwards. Frozen shoulder is something that is really common. It's often poorly understood, but the main problem with frozen shoulder is where the capsule or the soft tissue lining around the ball and socket of the shoulder joint becomes inflamed. It's also called adhesive capsulitis. It happens often for no good reason, but it is more common in certain groups. And so these groups can include people who play tennis. It's more common in women, typically in your 40s or 50s. It's associated with hormonal things like diabetes, thyroid, or around the time of the menopause, but we do see it in people who don't fall into any of those categories. And certainly if you're developing a frozen shoulder, it would become really difficult to continue playing tennis. Most cases will resolve without surgery. The inflammation of the capsule is the main problem, and that's what gives the pain to begin with. And then as the capsule becomes more inflamed, it gets thickened and tight, and the shoulder gets really, really stiff. So we use anti-inflammatory strategies to try to hurry up the natural process of this settling down. Sometimes oral tablets just aren't enough because the pain can be quite severe. So we often inject the joint with cortisone, and it's important where that injection goes. So again, a shoulder specialist will inject right into the main joint where that capsule is all inflamed. Sometimes we might even use a short course of oral steroid tablets. And we use really gentle stretching. The instinct sometimes when a shoulder is stiff is to push it and try to stretch really hard. But with frozen shoulder, the more you are aggressive with it in these painful stages, often the more that can aggravate it, and actually it can end up as a vicious cycle of just inflammation and pain. And so we just use a gentle stretching program and usually avoid formal physiotherapy. Often when the swimming pools are open, we use swimming pool based stretches as well to help get the range of motion back in the shoulder. And so these are some of the stretches, and this is Orla, the physiotherapist who works at my practice and who helps patients navigate this. In a very small number of cases, we consider surgery for frozen shoulder if the symptoms are not resolving. And that's a keyhole surgery where we release that thickened, inflamed capsule. The old way to do it was to manipulate the shoulder under anesthesia, but it's much safer and more controlled now to do it as a keyhole surgery. And we'll often use a nerve block as well as the general anesthetic to allow for immediate stretching afterwards. Once we have released the shoulder, it's different. Then we will be aggressive with physiotherapy because we don't want that capsule to scar back in. And it'll take a few weeks for all of that to settle and to allow somebody to start to get back to high intensity activities like tennis. And obviously after any intervention on the shoulder, if you're getting back to tennis, you go back gradually and take it one step at a time, small steps. This is what the inside of the shoulder looks like if there's frozen shoulder. The cartilage is on the left-hand picture. You can see the cartilage of the humeral head and then a really angry, red, nasty capsule that we're dividing with a radiofrequency device. The other diagnosis that we come across in shoulder quite a bit is arthritis, and this can affect our tennis playing population, particularly in later years, but actually you can see arthritis even in slightly younger patients too, and it can be a challenge to manage for younger patients. Shoulder arthritis for us means cartilage wear of the main shoulder joint, which is the ball and socket joint. On almost every MRI scan of a shoulder, there will be some arthritis or wear of the AC joint or the acromioclavicular joint, which is the joint between the end of the collarbone and the point of the shoulder. And often that's not actually causing any symptoms. So if you have an MRI scan and you have shoulder pain and it says arthritis of the AC joint, there's a good chance that's not actually what's causing your pain, unless the pain is right at the top of the shoulder if somebody presses on the AC joint. That's not what we're talking about when we're talking about shoulder arthritis. We're talking about the main joint, so sort of like the hip, the ball and socket part, and that can become arthritic when the cartilage wears. And you see an irregular shape and loss of the joint space. That can lead to stiffness and difficulty moving, which is a different stiffness than what somebody with frozen shoulder has. And unfortunately, with arthritis, there's not really any way to undo the arthritis. There's not really any way to put back the cartilage that has been worn away. So we use strategies to try and work around it. And the strategies center around pain relief, sometimes with physiotherapy, again, being gentle with the range of motion. If it seems to be aggravating the shoulder, we'll back off on it. Various injections can help with shoulder arthritis based on steroid injections, or there are what we call viscosupplementation injections. Those are sort of a gel type injection that mimic the joint fluid and can help sort of lubricate the joint, and some patients get relief from those. We can use something called platelet-rich plasma, which is where your own blood sample is taken and spun down, and then the platelet-rich fraction of that is injected into the joint. Sometimes in earlier arthritis, that can help. And then in some cases, a keyhole surgery might be appropriate in shoulder arthritis. Again, it depends on the stage of the arthritis. Sometimes the arthritis is too advanced to consider that, and we actually think about shoulder replacement, which is something that people hear about less commonly than hip replacement, but it is something that's really successful for shoulder arthritis. It's the most definitive way to treat the arthritis because it's the only way we can actually get rid of it. How long the shoulder replacement lasts can be affected by how you use the shoulder, and in terms of how much you do with it and how high impact the activities are that you do. But a lot of sporting and recreational activities are possible with a shoulder replacement, including tennis. I would absolutely let a shoulder replacement patient of mine play tennis once they've worked through the rehabilitation afterwards, which does take a number of weeks to months, and it's probably going to be 4 to 6 months after a shoulder replacement before we let you back on court, particularly hitting a serve. When we do a shoulder replacement, we get a CT scan and we actually plan the surgery with 3D software so that we know exactly all of the pitfalls in that individual person's shoulder before we get in there. This is a good example of getting back to tennis after a shoulder replacement. Tom Brown was a US professional tennis player. He passed away a few years ago, but he played in the era of Jack Kramer, right before professional tennis came in. And he was Kramer's doubles partner and also a really accomplished singles player himself, making it to Grand Slam semifinals and finals. He had a shoulder replacement, and 4 months afterwards was back on court and actually regained his world ranking in the over 65s, having had a really successful shoulder replacement with a surgeon named Tom Norris in California. And I think most of us would be happy to let a patient with a shoulder replacement back on court. There are two types of shoulder replacement: the anatomic type, which is we replace the joint as it is with the ball and socket, or a reverse type of shoulder replacement where we actually put the ball and socket the other way around. The two main reasons that we might do this would be if the rotator cuff tendons are no longer there around the shoulder, if they're torn and not working, the regular anatomic type of shoulder replacement can't function. So the patient needs a reverse. Or if the socket of the shoulder is so worn that we can't fit this white plastic socket in there and it's not going to be stable, then we also would do a reverse shoulder replacement. They work in very similar ways. There are some minor differences. The rehabilitation is the same. And again, I think a patient with a reverse shoulder replacement can get back out there and play some tennis as well once they've recovered. What a shoulder replacement involves as a patient is usually about 2 nights in the hospital and 4 weeks in a sling afterwards. Often people feel really good really quickly after a shoulder replacement because we've taken away that arthritic joint, so the pain relief can be quite quick. But it's a case of being patient in terms of working through the rehab and getting back to things like sports. This is how we do shoulder replacements, how we plan them, and the future is actually here in the sense that we have this software which allows us to see in 3D our patient's shoulder. We can even get a 3D printed guide to help us place our components really accurately. And now we can actually use this plan in a mixed reality setting where we wear a headset and that's projected right in front of us as we operate. I've been really privileged to be one of the first surgeons to be given that headset, and later on this week we're going to do the very first case in Ireland this Friday right here in Dublin, where we use this technology. And all the time the field of shoulder replacement is advancing. So it hasn't been around maybe as long as hip and knee replacement, but huge advances are being made, and so that allows it to be a very successful intervention for our patients. So coming back to tennis, I think all of us know that it's a sport for life. Kids can take up tennis pretty young, and I have patients in their 80s and 90s who still play tennis. And the benefits of staying active, both the mental and physical benefits, often outweigh any of the wear and tear that's sustained along the way. So I think keeping the simple things in mind to preserve your shoulder longevity while you're out there will make it so much more enjoyable, and hopefully avoid you getting into trouble with the shoulder. So the things that we were thinking about, like the kinetic chain, the whole body working together, the footwork to make that happen, and some of the things to be smart about with your gear for tennis. And hopefully that keeps you out of trouble. But if you have shoulder trouble, then there are plenty of things that we just discussed that we can do to help you out with it. Thank you very much.
Ruth, thank you for a really informative talk, and thanks everybody for joining us. I'm Fiona, I'm the Business Development Manager here. So our next talk will be Neil Welch, and when Neil's finished his talk, we're going to have live question and answers, because Ruth's talk was pre-recorded. So a little bit about the hospital, if you don't know, we're situated about 10 minutes from Dublin Airport, and we specialise in orthopaedics, so it's all joints here, anything musculoskeletal, sports medicine wise as well, with 7 theatres and 83 beds, so, and over 40 consultants work here. Now you can see there's a tab there, ask your questions, so please ask questions, we'll answer them after Neil's talk. Also there's another tab there if you want to download the exercises, and there's some tennis warm-up exercises on there as well. And if you're with Tennis Club and you'd like to register with us about future events or any information, there's another tab there. So we have other events on as well that you may be interested in if you're interested in this one. So if you go to the website, there's a golf event and other public events as well, which talk about other joints in the body. So thank you again for joining us tonight, and I'll talk to you after Neil Welch's presentation.
Hi everyone. My name is Neil Welch. I'm head of SSC's Lab Services here at the Sports Surgery Clinic in Santry. I'd like to take a minute just to say thanks to everyone who's watching today for taking time out of your day to listen. Hopefully you'll find the talk interesting, and you'll find it helpful to help you get back into tennis. I'm going to focus a little bit on today back pain. Because it is the most common musculoskeletal condition that we deal with. And very often it can be very debilitating and stop you from doing many of the activities that you want to do. In this instance, obviously, tennis. So we're going to talk about how we can stop your back from stopping your tennis. Now, if you do experience low back pain, and I suspect there's a good few of you who are tuning in who are dealing with it, I've no doubt that you've tried lots of things to try and help yourself get better. And that's really common. You know, we have a problem that we try and solve. We're feeling uncomfortable and we're feeling sore, and we reach out for some methods to try and assist. So we might take action by using something like a back support to try and reduce the load on the back, and that's a common approach. It would also be very common to make other lifestyle adjustments. So I've had people email me lists of mattresses and for advice on what mattress to pick up. And I wouldn't be the world's foremost expert on mattresses, and neither do I think that's going to be the way to solve low back pain either. Similarly, I've had lists of chairs sent to me. And now if anybody has managed to swing one of these for their office at home, fair play. But again, I'd be of the mind that some of these external solutions, the supports, the mattresses, the chairs, might not be the best approach for improving your back. Similarly, we look for remedies as well. So whether we try dry needling or acupuncture, or something a little bit more extreme. And the use of cupping seems to be a little bit more common these days. And I guess with all these approaches, they kind of make sense in one way, because we're looking for ways to improve our situation. And very often we look for ways that are external to us. So we're looking for the magic pill or the silver bullet to make us better. Sometimes we go in the way of exercise, but frequently when we look at the exercise solutions that are offered up, and these images are actually from a research study looking at the impact of exercise and low back pain. I guess two things kind of stand out. One is the research evidence around exercise is mixed. And when you look at the type of exercises that are being used, I guess you might see a reason why. I'm a strength and conditioning coach by trade. So when I look at these images and I look at the exercises and maybe what they're trying to achieve, the only thing I can sort of see from this intervention is that this person, if they do this for a period of time, is going to get better at balancing on a red ball. So what I want to do today is talk you through maybe some of the factors that might be a little bit more effective for helping you manage your back and keeping you on court. So when we talk about low back pain, broadly speaking, we're not talking about the spine itself. Now, I'm sure lots of you have had scans of your back and have shown disc bulges or changes in facet joints, but these are very common elements or findings on an MRI scan that people without low back pain have. More often than not, what we're talking about is muscular issues. So when we find we're a little bit sore kind of either side of the back, we might be thinking that there's an issue with our lumbar extensors. Now, these guys are active in lumbar extension. So when you arch your back, those muscles are working. They also play a role in stabilizing the back, but you can see where at the very bottom of the orange and yellow images, they're your lumbar extensors, where they attach to the pelvis. So they can be active in trying to control the movement of the pelvis and extend the hip. So once we start to understand the role of the muscles, we can maybe start to figure out why they might be doing a little bit too much work for us. Some of us might be finding that when we get a sore back, it's a little bit more out towards the side. So what we would call our lateral quadrant. And one of the muscles out there that contributes is what we call our quadratus lumborum. Now, again, this is a lumbar extensor. So again, it helps you to arch your back. And again, if you utilize those strategies quite frequently, and that might be a reason why those muscles are taking on more work. They're also responsible for assisting in lumbar lateral flexion. So that's bending over to the side. And what they also do is help control the pelvis. So they help provide stability when we're on one leg. So broadly speaking, when we're thinking about low back pain, we're trying to understand why some of these muscles might be doing a little bit more work than we want them to. And what we also need to do in context as well is try and understand the role they might be playing while you're playing tennis. Okay, because ultimately that's what we're discussing today is how to keep you guys on court without your back from stopping you from doing that. Now, when we consider the musculature in the back, there's a few areas that we're looking to try and consider. So I'm sure people have heard and been told, I'm sure in the past, that the hip flexors might be a little bit weak or a little bit tight. This is one of your hip flexors, your psoas muscle. It's attaching to the front of your spine and crosses the hip. Now, in this instance, the reason I'm showing this is to give you some idea of what a well-conditioned psoas muscle looks like. Okay, so the dark grey image there is muscle. Any of the white bits you can see kind of, and you can see towards the bottom of the green box, a whisper of white marble, and that's fat. These are your lumbar extensors. So again, same sort of thing, give you some idea of what a well-conditioned set of lumbar extensors looks like. A little bit of marbling in there, indicating some fat infiltration within the muscle, but only a small amount. Like looking at this on the scan, you're looking at a very well-conditioned set of lumbar extensors and hip flexors. And just to give you some context, what happens when we're a little bit deconditioned, or a lot deconditioned in this instance. So again, we think about that psoas muscle, we think about the size and strength of that. So we're likely going to be weak here in our hip flexors, but then we can see the degree of fatty infiltration within the lumbar extensors. So a lot more towards the rump steak end of the spectrum rather than the fillet steak. And we can start to understand then maybe why some of the muscles in the back might not be coping with some of the work we're asking it to do, particularly if this is the condition they're in. So we were looking to try and increase the strength of our back, and there are certain exercises that we can do. So I'm going to talk you through a deadlift now, which would be one of the ones that we would use in order to be able to increase the strength, I guess, of the muscles up the back of the body as a whole. But we've some research published that shows the increase in size and the reduction of fat within the muscles in the back from doing this. So this would be a deadlift movement. We're going to show you it in a rack. So once we're back in gyms, hopefully you'll be able to do this. But if you have dumbbells at home, you'll be able to pick these up off the floor. The most important points here are at the top of the lift, where Jack is really working on squeezing his bum. And on the way down, most of the movement is from the hips. So he's working very hard on pushing his bum backwards. And if you're doing this right, you'll feel the muscles down the back of the legs feeling like there's a big stretch on them. So Jack will be feeling a stretch down his hamstrings and in his bum here. Most importantly, really, with this, is you shouldn't feel like the back is doing most of the work. We're targeting the hips with this exercise, and the back is playing an assistance role. So if we think about our lumbar extensors. So I said before about them being active in lumbar extension. So if you arch the back a lot, they're working quite hard. And the key bit as well for me is the last point, hip extension. So if your primary hip extensors aren't doing the work as well as they might, then you might be recruiting the lumbar extensors a little bit more. So essentially, if the hips don't do the work, your back has to do a bit more. And our primary hip extensors are glute max. It's the biggest, strongest muscle in the body. And again, as I said, if we're underactive here and not very strong, then we've got to start considering what other structures are going to take that work on. So we were looking to try and increase the strength of our glute max. And this is probably one of the most important exercises that we use regularly here at the Sports Surgery Clinic. For hamstring issues, for hip issues, for back issues, it's very common to have some weakness in our glute max. So a single leg hip thrust is a really good option for you. So you'll see here the setup is to have the back on the bench. And you'll see Jack here, he's keeping his eyes pointing straight down the gym. He's not throwing his head back and his ribs up. The idea there then is that all of the push and the movement comes from his bum. So you'll see again when we go through, he's working very hard with his left glute to push up and squeeze and to lock the hips out using the bum. And that's what you should feel when you're doing this. You should feel like your bum is working really hard. Now again, progression with that is to start adding weight by putting a dumbbell on top of the thigh. But if you can manage that with your body weight, then you're doing all right as a starting point. If we start thinking about those of us who are dealing with more lateral low back pain, it's very common when you can kind of tell when somebody starts rubbing their back and they have the chicken wing, the elbow out to the side, and they're rubbing towards the side of their back. This is more the area that we might be thinking about. So it's an active lumbar extensor as well. So we can't discount the two exercises we've just done that should help. But they're also important for helping provide stability around the pelvis. So if we look at what else provides stability around the pelvis, again, it's one of our glute muscles, our glute med. This is going to be an important one for us to exercise as well. So how we might get after this is through a relatively basic climb exercise, but there's a couple of important points here. So keeping the heels together, slowly dragging the knees apart, and just making sure we're not rolling backwards away from the floor. Okay, so if Niall here was rolling back and starting to point his hips up towards the ceiling, then his bum isn't going to do as much work as we'd like it to. So he wants to keep his right hip rolling forward, and his hand will provide stability there. Slowly pull the band apart. And if you're doing this right, you'll feel a really strong burn sensation going on in the side of the bum cheek. Okay, and that would be our glute med taking on some work for us. Now, with all of these exercises, you should feel like you've had some improvements immediately after doing them. So the back should feel a little bit lighter and a little bit looser. Now, obviously in tennis, there's a lot of rotation involved. And sometimes we can use our muscles in our back a little bit more when our abdominals aren't doing enough work. Okay, so this is where some of our rotational exercise, in order to be able to target some of the muscles around the the front of the body and get them doing a little bit more work for us. So a half kneeling Pallof press is a good option here. All you need is a band at home. So some tension on the band, we're on one knee, and then we're slowly pushing the hands out in front of us, and we hold. And we're just resisting rotation. So the hands ideally stay in the midline of the chest all the way through. The band doesn't get an opportunity to pull us closer to the rack. Okay, by doing that, what you should feel is the muscles around your stomach resisting that movement. So Jack here should feel the sides of his stomach working quite hard. Again, just going to a point where you feel fatigue in the muscles on in the stomach, and then switching sides should help, again, reduce some of the loading on the back, as well as obviously help our performance when we're playing. Now, one of the important factors, again, when we start more considering overhead work, so obviously serving is a large component of what we do when we play tennis. Trying to understand the range of motion that we have in the shoulder becomes important. So one of the tests that we do for this is our shoulder flexion. So just lying on your back and seeing whether you can get your thumbs over your head to the ground. Now in this second part here, I've just tried to flatten my back. It's a little bit harder, but I've got decent shoulder range of motion, get my thumbs to the floor. If I arch my back, it's a lot easier. But what that's telling me is that I'm borrowing a lot more range of movement from my back, and it's not my shoulders necessarily doing the work. So if you find with your back flat that you're not able to get your hands to the ground, again, I'll replay that. So if on this second example in the middle here, I've got my back flat against the floor, and I can't get my thumbs to the ground, then I'm lacking a bit of shoulder flexion, which means I'm going to struggle with anything overhead, or I'm going to borrow from my back in order to be able to get my arms overhead. So one of the reasons we get back pain on our overhead movements is because we're lacking shoulder range of motion. Now, if you tried that yourself at home, there are some exercises we can do to help it. So first part, like a relatively basic exercise here, would be taking a bit of TheraBand, keeping some resistance on it, trying to keep the back flat, and just trying to work through a greater range of motion. So one of the reasons we sometimes lack range of motion around the shoulder is just because we don't train ourselves to get into those positions. So simply by adding some of these exercises to your routine, you'll find that your shoulder range of motion improves. So pushing out against the band and keeping the thumbs pointing backwards will activate the muscles in your rotator cuff. So it'll be a good rotator cuff workout, as well as improving your shoulder flexion range of motion. Now, shoulder rotation is a very important component within tennis as well. And testing your range of motion here is something you can do to find out whether it's an area you need to develop. So just resting your elbow on a cushion, keeping your legs flat, and just seeing whether we can get the hand back towards the ground. Now, the temptation here is to reach with the fingers rather than trying to get the back of the hand / wrist to the floor. Now, a lot of us will struggle in order to get the hand all the way down to the ground. In which case, again, we're lacking some rotation range of motion, which very often comes from the muscles controlling the movement rather than the joint itself, which means that it's trainable. So an exercise that we can do, and I'd argue this is something we should be doing if we are playing tennis anyway. Providing stability and control around the shoulder is really important, and our rotator cuff muscles are really important for this, some external rotation work. So again, a very simple exercise, small dumbbell at home. Just have the elbow resting on the knee, and then it's a rotation we're looking for. So the elbow should stay at 90 degrees all the way through, and exactly where I'm grabbing my shoulder there is where you want to be feeling it. Sometimes it'll take a bit of work and a bit of playing around with the technique to make sure you're feeling it at the shoulder blade, rather than say at the front or the top of the shoulder. We'll play around with the exercise, and as soon as you have it, then a little bit of work taking that muscle to fatigue will start to condition the rotator cuff. And again, there'll be some of us here who've had to deal with rotator cuff tendinopathies in the past, and this type of exercise will be a really important part of your rehab. So again, by starting to implement some of these exercises into your routine, first of all, it should stop you getting injured. And if you do have some soreness, it will likely take care of a lot of it. Okay, so hopefully that gives you a little bit of an insight into some methods that you can take on yourselves to help with your back, to help train some of the muscles around your back so that you feel a little bit less discomfort, a little bit less pain, and help you get back on court. And the shoulder obviously is a really important component with playing tennis. Test your range of motion out at home. So try those little tests that we put up in the presentation there. And then what you should find gradually, if you are consistent at those exercises, is when you go back to retest your shoulders, you should notice some improvement. And if you need any more help at all, feel free to contact us here at the Sports Surgery Clinic, and we'll see if we can help. And thanks very much for taking the time out to watch the presentation. And we'll be back on shortly for some questions and answers.
Ruth and Neil, thanks very much for that. So we'll jump into some questions now. Now, some of the questions that people are asking, they cover a lot of areas, and a lot of you are asking the same questions. So we'll just group the questions together. So the first question is about the rotator cuff, and how long does rotator cuff tendinopathy take to heal? And it will depend on severity, but in general terms. And then they're also asking for some exercises to help with healing. So Ruth, if we start with you, and then Neil can jump in.
So yeah, there is a spectrum of tendinopathy, and there will always be a normal amount of wear that's seen on an MRI of a shoulder. So it depends how the diagnosis of tendinopathy was made. I would be very slow to make it just based on an MRI image. If there's pain associated with it and inflammation around it, it can take time to settle down, of the order of months. And it kind of depends whether you're actively treating it in terms of things like injections, physiotherapy. That should hopefully shorten it,
Yeah.
but I would say typically 2 to 3 months.
Okay, thanks, Ruth. Neil, some simple exercises.
Yeah, I included one in the presentation towards the end there, the one where they sat down using the dumbbell.
Yeah.
There's just a couple of points with the exercise. You're looking to try and make sure you take the muscle to fatigue, because usually when you have pain in a part of the body, you lose strength around that body part. So you're trying to restore the strength in the muscle. The other thing you're looking to try and avoid is pain within the tendon itself. So none of the exercises should increase your tendon pain, and that's a really important part with the rehab.
Okay, thanks. And look, for anybody that's watching this now and they want to see the exercises again, we will be sending you a link for this so you can watch it on demand. So you will be able to see those exercises. The next question then, a person had the long-standing minor shoulder injury which restricts movement when playing tennis. Any view on shoulder support braces?
We don't use them that much. The times that we use them are typically for the opposite of restricted movement. When somebody has sort of too much movement and instability at the shoulder, we might use a brace for that. If you have something minor that's kind of restricting movement, often it probably won't feel much better with a brace, and the brace will just restrict movement even more. So I think it's a case of trying to settle down the minor injury. But you know, if it feels better with the brace on, there's no harm. It's not going to really do any harm. But
yeah. Someone's asking, they had a frozen left shoulder and got an injection. Have been doing stretching exercises since. Seems fully recovered, but what ongoing strength and mobility exercises should they do to for preventative maintenance?
Sure, I'll take that one. First of all, great to hear they've come out the other side. The frozen shoulder can be a bit of a journey to get through. The main bits, assuming it's fully recovered and you've got full range of motion back, is just trying to restore any strength that you've lost in the shoulder. So a general upper body program, including a couple of the shoulder exercises that I've included in the presentation, but general push-pull exercises such as working towards full press-ups, any pull exercises, any row type exercises is going to be a benefit to the shoulder there as well.
Okay, thanks, Neil. Now, and the next one then, somebody's talking about they've actually hurt their wrist playing tennis a few months ago and developed a ganglion on the top. Only has pain when they do push-ups or plank type exercises. Is it okay to ignore this for a few months, or do they need to get seen as soon as possible?
Yeah, I suppose, look, wrist is not my subspecialist area, but in terms of ganglion cysts in general, if it's minimally symptomatic, it's okay to leave it alone. Yeah,
okay, thanks, Ruth. And what would you recommend for shoulder pain due to biceps tendonitis? And also, what's your opinion on extracorporeal shockwave therapy for inflammatory conditions of the shoulder?
Sure. Well, biceps tendonitis, usually up around the shoulder, there are two biceps tendons heading up towards the shoulder. One, the longer one, goes through the shoulder joint and actually doesn't really do very much of the work. The shorter one, which is outside the joint, tends to do most of the work. The longer one that turns a corner and goes up through the shoulder joint is the one that usually gets inflamed when you have biceps tendonitis up at the top end of the biceps. And Neil can probably speak to this in terms of exercises. Often we find that what we call eccentrically loading the tendon, so loading it as it's getting longer, so as you're straightening the elbow, can help. So it's something we do use physiotherapy for. And the shockwave therapy question, the thing that I would usually use that for is calcific tendonitis in the rotator cuff. Would be kind of the main indication around the shoulder. I'm not sure that it would make a big difference to biceps tendonitis, but you could talk to a therapist. Neil, I don't know if you have something about exercises for biceps tendonitis that you'd add.
Yeah, sure. You'll quite often find people will go to stretching as a main exercise to try and assist with any tendon issue, really. And that's one thing that the tendon doesn't like. You're going to aggravate it even more. So you try and stick to strengthening exercises. If it's a biceps tendon, making sure everything is strong around the shoulder, but you can do local exercises such as bicep curls to assist with that. And as Ruth was saying, eccentrically loading it. So if you imagine a bicep curl being you bending the arm up and then slowly lowering it would be the eccentric portion of that movement. So if you control that motion, you'll load the muscle. But again, as it's a tendinopathy, you're trying to avoid pain in around the tendon site itself. You're loading the muscle rather than trying to target the pain site.
Okay, thanks, Neil. Here's one, Ruth. Do you need a referral from a GP to attend sports surgery clinic?
So it can vary from consultant to consultant, but in general, you don't necessarily have to have a referral from your GP to come see me. You don't need to have a referral letter. It's helpful if you have your entire medical history and a full list of any medications that you take, but your GP can refer you, your physio can refer you, or you can also self-refer through our website, but your GP will always be informed about your visit. So we'll always send a letter back to your GP then after you've come.
Yeah. And I think that's the same for a lot of consultants, but especially the spinal consultants would always want a referral from a GP or a physio as well. And Neil, for sports medicine, you don't always have to have a referral from a GP either, do you?
No, we're open house, so self-referral is fine for us as well.
Yeah, exactly. Good, thank you. Another patient then had pain at the top of my shoulder. It's ongoing. Could it be a trigger point and do I need to work on it, or should I be doing more specific exercises?
I suppose it depends whether the pain on the top of the shoulder is coming from the AC joint, so the joint at the end of the collarbone and the point of the shoulder, which can be right there, or it could be a trigger point in your upper trapezial muscle. And so it's hard to tell without someone actually examining you which it is. If it's a trigger point, then it can respond to manual therapy, and sometimes trigger points are injected. If it's the AC joint, that can be injected with steroid and occasionally keyhole surgery to just excise the little joint. So it sort of depends on exactly where the pain is coming from. Okay, thanks. And Neil, any specific exercises on that one, or does it need diagnosis?
Yeah, a diagnosis first on that one. Just pop down to a local physio. They should be able to help guide you in a certain direction. Then.
Yeah, thanks. Are shoulders sympathetic? Someone's asking. I injured my left shoulder a year ago through a fall, and now my right shoulder is sore, but not in the same place nearer to the neck. A couple of ways that can happen. It's common enough. One is that if you have one shoulder that's sore, then you're tending to probably use that shoulder less, and you're going to use your other shoulder more. So a bit of overuse of the non-injured shoulder can lead to some inflammation flaring up in the non-injured shoulder. The other way it can happen is just having a sore shoulder on one side can lead to tightness in the upper trapezius on both sides, and the shoulder blades can be sitting a little bit differently, so you may have pain in the upper trapezius muscle on the opposite side to your originally injured shoulder. Okay, good. Okay, and here, Neil, both of you, are injections just a quick fix? Is it better to do physio, yoga, or are injections the thing to do?
Depends on the diagnosis. There is definitely a sort of a feeling out there that injections sort of mask things and aren't good. And that's the case if there's a structural problem that maybe needs to be fixed or addressed differently with physiotherapy. If there is an inflammatory problem, then an injection of a big time anti-inflammatory, a corticosteroid or cortisone, makes sense because you treat the inflammation. So I think that the answer to that question really depends on the diagnosis, and it's never an injection by itself. An injection might be part of an overall solution.
Okay, thanks. Okay. Many of us don't have dumbbells. This is for you, Neil. What exercise could they do instead?
Yeah, so I think they're referring to the deadlift exercise in the presentation. It's quite challenging to load that exercise heavy without dumbbells, but there are loads and loads of alternatives. Lots of single leg exercises that are possible to take up at home that are quite challenging just using your body weight. And again, there's lots of other options for fitting out home gym and home workouts. Stuff like resistance bands can be a very useful tool to do that. Okay, thanks.
Neil, what's your opinion on Pilates and foam rolling? Help or hinder?
Well, again, I'm going to throw out a big it depends at this on what you're trying to achieve. If a foam roller makes you feel good before and after playing tennis, then it's beneficial. It's not necessarily going to make any muscles longer or stronger. Pilates, again, it's a personal preference as an exercise form. It's one of those exercise modalities that's quite good for training the abdominals. But in terms of increasing your strength per se, like my opinion would you need something with it be a little bit more challenging, and resistance training would be the best way to deliver that.
Okay, thanks. How effective is placing ice on the shoulder to tenderness, such as using bags of frozen peas?
Yeah, it can be. I mean, look, ice, cryotherapy, you know, there's lots of fancier ways of doing it than bags of frozen peas, and they're probably not much different. We use it post-surgery, sometimes for swelling, and it can help when there is something acutely inflammatory. So often we'll tell people who have really inflamed shoulders, like for example, frozen shoulders, to use heat in the morning or heat before they're going to stretch to kind of loosen out the muscles, and ice then afterwards or at nighttime to cool it down. So generally, I suppose we think of heat as being useful for muscular pain and tightness, and ice as being useful for kind of acutely inflammatory pain. So depending what's going on, it can help. If you find it helpful, it's certainly something we do use.
Okay, and a lateral tear in the hip, that's a hip exercise. So Neil, would back strengthening exercises help with that?
Yeah, there's a couple of the exercises within the presentation again. So the deadlift, the hip thrust, and the clam exercise, they'd all be great for conditioning the hip. Just with a labral tear, like in some instances, they can require a surgical opinion. Many of them are asymptomatic though, and do well with rehab. But just to bear in mind, at some point down the line, you might need a little bit more guidance than just the exercises from the presentation.
Okay, yeah. Is eccentric exercise effective in rotator cuff tendinopathy?
Yeah, they can be. Like again, probably not to start off with. So we'd use what we call isometric exercises, where there's no movement to it. Essentially, you're loading the muscle without it moving. The evidence around that is that it has an analgesic effect, so can help calm the pain down. Eccentric, and again, obviously it depends from case to case. If you go straight into eccentric exercises, it can be a little bit too much load to the tendon, and you can aggravate it more than help it initially. So isometric first, and then you generally move on to eccentric.
Okay. How do I protect a hypermobile shoulder joint as I get older? Ruth?
Yeah, it's an interesting one. Usually hypermobile shoulders are more of a problem when you're younger, and as you get older, because our ligaments naturally tend to stiffen up a bit as we get older, you lose some of that flexibility. And in a lot of people, that's not good. If you started out hypermobile, that's helpful, because as time goes on, you lose a bit of that hypermobility. If you're still truly hypermobile in the shoulder, then the best way that you're going to protect it is by strengthening everything around it. So the hypermobility is going to be the capsule, or the sort of the ligament layer, that's the deepest layer around the shoulder joint. But then you have all the rotator cuff muscles just above that, and then the bigger sort of deltoid and pec muscles around it. So particularly the rotator cuff muscles, the smaller muscles, those are dynamic stabilizers of the shoulder. So if you can strengthen those, that will help compensate for your hypermobility and help protect your shoulder.
Okay, good, thank you. And Neil, any advice on treatment for muscular pain under the shoulder blade near the spine, or exercises?
Yeah, again, like with kind of many of the questions we're getting, there's many factors that kind of can contribute towards that.
Yeah.
In general, maintaining I guess healthy upper body strength through pushing and pulling exercises isn't really going to have any negative effect, and it tends to be one of the areas that people don't do too much of, even like if they train at home and don't have access to a gym. So training the upper body is actually a really important part of, I guess, a well-rounded strength training plan, especially for a sport like tennis, where the upper limb is so involved. So basic pushing and pulling exercises, either using a resistance band or a cable machine for the pulling. Being able to press up, I think, is a really important strength skill. And the majority of patients who we would see who aren't completing regular upper body training wouldn't be able to complete, say, a single press up. So there's a decent starting point there to work towards.
Okay, thank you. Just leave this here. Hill-Sachs lesion post dislocation of shoulder. Should I expect restricted range of movement, or should I be looking at a surgical option?
So what a Hill-Sachs lesion is basically if the shoulder dislocates. So say if my fist is like the ball and my other hand is the socket, and the shoulder comes out of the socket, the back of the ball hits the front of the socket when the shoulder's out, and then the shoulder's put back in, but often a divot has been left in the back of the ball. This can predispose to future dislocations, because now if there's a divot in the back of the ball, it's easier for it to jump out over the front of the socket. It wouldn't necessarily restrict range of motion, but it might inhibit stability. It depends on what age the person is. So you'll see a Hill-Sachs lesion after a lot of dislocations if it's small and shallow, and if the patient is over 25 when they've had their first time dislocation, then often they'll get away without surgery. If you're under 25 when you dislocate for the first time, there's a high chance it's going to happen again, and so surgery might be considered. So it sort of depends on the exact individual situation, but a big Hill-Sachs lesion, probably worth coming and having a chat with a shoulder surgeon.
Okay. Listen, thanks guys, and thank you everybody for joining us tonight. And just to remind you, this is our first talk we've done on tennis. So we're going to send out an evaluation for you, and if you have any ideas about other talks that you'd like, please, we'd be delighted to hear about it. Also, we have that button there, the tab for about register your club. So if you want to register your club with us, please do, and you'll know about future events. And if you've any other questions, we'll get back to you. So thank you again, Neil and Ruth, for your time tonight. If you've any questions that you have put in that we haven't answered, we will have a look at those as well and see if we can email you the responses back. Thank you. Good night. much.